I'm going to sandwich. We have a sandwich in this New Frontiers panel. And I'm the end of the sandwich, or the outside. The first part you heard Jenny eloquently discuss program building. And we just heard, I think, really important aspects of research that we're thinking about together. Together meaning medically, musically, but also Dory touched upon areas of pain that we need to be thinking about. And I really like the part, Dory, about the music aspects, that we need to say more than the music helped. Or was it live music or recorded music? Like we think that's enough. That's not enough. And when I read Sherry Robb, who talks about in our research and in our clinical practice, we, all of us here, need to talk about the exact elements of music. It's not enough even to say live or recorded the piece of music used. We thought Saturday Night Fever was saying it all. But even then, that's not enough. So what recording of Saturday Night Fever? Who's going to sit down and analyze Saturday Night Fever and that peak? And the timing and arousal and expectancy. Who's going to do that? We are. We're going to have better literature then. It's not enough to say the piece. It's not enough to say recorded or not recorded. Somebody has to sit down and actually look at the medical ailment and look at the music intervention used and when it started and when it stopped and how long and the brain. So it's up to us to do that. So I'm going to, just let me keep going because I'm really short on time, but I'm going to sandwich these two beautiful presentations because, as John said, we've been doing this here about 18 years. So we're going to look at program building, which we constantly have to do, the research outcomes and what we have to keep churning, and how we put both of those together to really keep music medicine and music therapy alive. And we can't do this separately anymore. We can't have articles streaming around called music therapy that aren't music therapy. On the other hand, music therapists have to work with people doing this research so that we integrate. So I'm going to end this sandwich today to say a new frontier, even though it's not, if you talk to people like Cheryl or Paul or Suzanne, this is not a new frontier, but it is kind of a new frontier because Tremo talked about the now. The now is doing it in the moment. So how do we do it? And that's what I'm going to talk about a little bit. So new frontier, summing up what you just heard, is showing, doing the clinical research well, and showing it in our daily work. So let's move ahead. All right, so big risk to show you this tape, because I'm pretty much a shy person. My friend Ellen Turia at Nordoff Robbins, they video every single moment. Yeah. So if somebody, burps, it's part of the oh, well, Clive, that's when you burped, But here, here at Beth Israeli, we are part of technology. Mark, you talked about books, and I'm thinking more computers. I wish kids would read, but we are technology. What we've heard 2 or 3 times today that we didn't hear yesterday is the idea of what I would call feng shui, the use of space, how someone comes into a space. You talked about fireflies. Mark talked about how we lay it out. So in our doorways, you might have seen when we come in, they have this video running of music therapy. It's not actually on music therapy. When you come in, it's probably a doctor talking about heart surgery or another doctor talking about spine surgery, but we were asked to put together in 3 minutes or less, our 18 years of work here. And so what's key in program building in New Frontiers is being able to show to the average Joe, they say a good speaker can relate to a child on a beach, a bartender, and a rocket scientist. So how do we do that to generate the clinical thinking that we want every doctor or nurse walking through the door to have? So our challenge was, by our media and hospital where you sit today, to come together with a clip that would say it all. So this is a clip that's playing in the doorways. I like to show it because it highlights the aspects of clinical research and thinking that we're doing enough for the vice president of cancer to understand, all the way to a little kid walking in who might want music therapy. So here we go. Music therapy is the use of music and sound to effect change. Hello, I'm Dr. Joanne Loewy, and I'm the director of the Louis Armstrong Center for Music and Medicine at Beth Israel Medical Center. Our music therapists, who are referred by doctors and nurses, are licensed and board certified in a specialty that reaches patients of all ages and all diagnoses. A premature baby in the neonatal intensive care unit, to patients with cancer or those with pain, COPD, or asthma. The therapeutic use of music dates back to biblical times. Modern music therapy became recognized as a medical discipline during World War II. It was nurses who found that music helped wounded soldiers heal. Today, there are more than 5,000 trained music therapists in the United States. And at Beth Israel, our Louis Armstrong Center music therapists are at the forefront of this emerging field, and we have been since the early 1990s. For example, we design music programs to mask the stressful noise of life-saving machinery in the ICUs.
So where there's music, how faint the tune.
We also host professional musicians who play live music in many of our waiting rooms and lobbies. Music has been proven helpful in teaching a child with asthma to control his or her breathing. We offer this not only in the hospital, but in the New York City public schools as well. Music can also reduce the need for medication for patients in pain. Each application of music therapy begins with an assessment, so we might learn how to bring music to meet a patient's specific needs. You might say at Beth Israel Medical Center, we are truly in tune with our patients. We are proud of our leadership role in research and clinical practice in this exciting field. So the idea, thanks. So the idea seems very simple. I mean, it was a bad hair day, and just getting over ourselves and knowing how to say, because with computers now, which is different than books, a bite of being able to say what we do is going to create that new frontier. And if we can feng shui it to be lodged in the doorways and have just bites of clinical moments, even that most of those are staged. The patient with cancer is Marie. Melanie doing the asthma is working with an intern. So it's ethical. But the power of people that I train that go around building new frontiers, the power of that promo, what I call promo video, will really generate the funding so that we will be able to do more of the research. Can't say enough about that. So I'm going to talk a little bit more. Things I want to do is take a step back. I want to hold hands with the doctors, and I want to look at music therapy as part of a bigger movement. Music and medicine as part of a bigger movement. We're no longer talking about alternative medicine. This came out of the 60s, really, 70s a little bit, and then we moved into complementary. But now if we look at the literature, we're calling it integrative. And integrative medicine, one factor of that is music therapy and music and medicine. But the other factors, if you look at the programs going on around our country and in different parts of the world, here are the outlines. Integrative medicine is emphasizing, I was so glad to see here Dr. Tramos said, the relationship between the patient and physician. That's key. We used to call that bedside manner. Now it's in their manuals. It integrates the best of complementary and alternative, since the New England Journal wrote about in the 90s that thousands of patients were using the herbs, even writing about the sleep, writing about what's used preventatively rather than extra. So it combines the complementary with the best of conventional medicine. There's a greater emphasis, not just on the car with the new muffler, right, but the driver. So the driver, what you think about your illness will gravely affect the outcomes, and we're noticing that. And that care is more patient-centered and inclusive of moods. HCAPs, JCO, they're asking about culture. And the inclusion of caregivers. We notice that no matter what you're doing, if you have a caregiver involved or at your side, or on the other hand, that caregiver is an antagonist, doesn't matter how good the medicine or how good the MRI looks. So we're looking at relationships, and that's how we build frontiers, is working in communities. We have to keep looking at the evidence, and these are bullets kind of talk about, discuss the evidence both psychosocially and medically. The relationship is key. And as I said yesterday, in music, we do it at the same time. So we're using transference, countertransference, but we're also in the pulse of the person's heartbeat. We don't actually need to take their pulse, because the expression of that pulse and being with them at that moment might be, in certain situations, the event of change. These are kind of the sources of evidence that I'm looking at, and it's what I'm in the process of writing about. The raw data, which is we need to always look at the patient's music, the use of self. Benedict Describe has written a lot about this. Our own observation, our own transference, countertransference is coming out in the work. We need to keep researching the phenomenon. Don't start it anew. It's already been written about. So take what was written and go ask the researcher. I've been calling people that work with babies in pain. What did you play? It wasn't in the article. I don't have to throw out that article. I can Google the person and find out what they played and how they played it, so that doesn't get thrown away. Noticing the surprises. When we think about penicillin, it was a surprise. So bringing up a net and looking at all the fish rather than just a particular worm that will bring you funds. That's why we haven't published a lot of our research, because we spend so long scrutinizing. And the team reports, so integrating. Building new frontiers means we include everybody in the person's regular life world, not just the petri dish of people that come before us in the moment or the data that we need for the research. But what happened outside there, if you don't know what's going on outside there, you don't understand the patient in the moment. So we build new frontiers with the community. And let's talk a little bit about community. I had my white coat on, probably coming from a procedure, and there's our community jam. Community jam happens on most of our units once a week, brings together the janitor, the clerk, the parent, the vice president of the hospital who is touring people around with a suit on. Everybody is in the Norton sweatshirt in the community jam. Because even if they have a white coat on, when you give them a maraca, it just changes the whole atmosphere. So if there's one gig you learn as a music therapist, it's how to do a community jam. And you can do it in the OR, you could do it in the waiting room. Very important that we keep active music playing live. We have access to creating and building new frontiers. We have portals of communication, and we may be the only person as a music therapist or music medicine, we're activating patients, families, and staff all at once. We're melding the groups that have disconnect. So you have rounds, and you have the nurse that's going to go after the social worker again, and you know that's coming. You can begin those rounds with a music meditation and maybe meld in the favorite music of both of them, and maybe they can reflect on it. That's not therapy for staff. That's just good community building, and that's how we build a new frontier. So music, to create this culture, we look at the opportunities, attitudes, values, goals, and practices that characterize the institution. I don't understand another hospital when I go there. In Singapore, that makes sense, and I didn't. They had robots that gave out food. That was interesting, right? But I don't even understand the culture of a hospital I visit in New Jersey. I don't. When I go up to Mount Sinai, I don't understand the culture there. Every hospital has their own culture. And if you look at every person having their own culture and go into the life world analytically of the music, that's how you're really going to program build. And I think we saw Jenny do that so well. She just went in and used everything she had. We don't use it enough, actually. I can't say enough about volunteers and visiting artists. So music play. We might be the only persons, too, who play. And it's we get paid to play. Those of you that are complaining about your salaries, you're getting paid to play. Look at it that way. Because when we elicit play, we elicit things like resilience and creativity. So we're looking at play that can break into the motives of not just patients, but our studies now are including caregivers and staff. And we do it metaphorically. Carol Merle Fishman's here. She taught me all about metaphor when I was an intern. We do it metaphorically. Because the quickest way to turn someone off is say, how are you feeling? One, it's none of your business how they feel. Two, feeling is icky. And three, you'll learn a lot better if you play music with them. So it's done through metaphor. We need to serve on bigger communities to build frontiers. And I've been lucky to be part of our destination diversity here. Whoever thought you would need a diversity destination committee in New York, you know? But you do. You have to address it consciously. Because even though we're better at it, maybe in New York, because we deal with it, there are roadblocks. So that's building new frontiers, too, is getting involved in other projects. We want to be more transparent and uniform in what we're doing. We want to be more consistent. So I just want to point out in building new frontiers, too, that they're being here so long, there's been a big movement to get people in and out of the hospital. Used to be a month, maybe 2 months, 3 months, right, Kate? Now it's like overnight. Get them out, get them out, get them out. And we can only go so far to block that. So what we need to do is create what we call wellness clinics. That's right over there, is our staying well, preventative medicine. So we're trying to avoid ER care rather than get the asthmatic, #1 diagnosis for children with asthma, right? In New York, children who have asthma is the #1 admittance to hospitals. So rather than get them when they fall down on the kitchen floor during the weekend and all of a sudden they have asthma, we need to teach parents how to use and prevent, how to use the kids' air every day so they're using their own air, how to keep compliant with the medications. Avoidance of ER care, continuity of care. It's not just send them home with a CD anymore. It's showing them their body's an instrument and giving them activities to do that. And community-based projects, so not just in the hospital, but how will you collect data afterwards, and professional education. And I think we knew early on that the best projects in building new frontiers were going over to doctors who were turned on by the music therapy and saying, you look really turned on by this. Would you like to be a co-investigator? All of our studies have co-investigators with doctors. So we can go back with questions. It increases our referral base, documentation, quality improvement, and to have a theoretical orientation. We do have to adapt that. It comes from good building and it comes from research, but it also comes from the deepest philosophies that we bring to the gig. So here for us, it's a music psychotherapy. It's a wellness model. It's a holistic view of the patient. We heard Dory brought in traumatization. We can't now put that in hospitals anymore. We learned it here a lot through 9/11, but anytime someone gets admitted to a hospital, there is some kind of trauma somewhere. Live music is a form we use here because we can change the heart rate, respiratory rate in the moment of what we're playing. Research is showing that. I still don't think machines can do it as effectively. I think recorded music inclusive of heartbeats, wonderful, but nothing like the moment. You know it because you've been in it. And the multicultural that we use. So there's critical relationships in frontier building that we need to look at between music and pain. If you think about this, pain is subjective. The literature showing us is multidimensional, and the special populations require different approaches. We can say the same for music as well. I think part of the wellness institution that we're in now, we're in a wellness age. It's not just yoga, chiropractic now. We are in a wellness model. So with that, we need to bring into the literature work words of wellness. When we think about Freud, we think about all the neuroses and illness. But resiliency, for instance, this is just one of our studies that we're doing. We're looking at resiliency and music's capacity to build resiliency. So that's our hypothesis. But what kind of music is what we're studying? And having multiple ways to look at expression of pain, not just the 0 to 10, not even the faces, but letting the patient draw it and characterize it. And then the use of other modalities. We heard in the lecture today about use of movement, which is part of music, and I think we can also use art. We're not art therapists, but if we let the patient draw or color sometimes, instead of talking, and then go to an art therapist or a psychologist. This was a child that had what? Can anybody guess? He said that was a gourd, and that's a bus, but what did we learn about him? Psychosomatic pain. And what's a big issue for young children? School phobia. Good. So we also need to have the attitudes of staff. And this was actually a personal reaction from an intern. And what he was observing was the amount of trauma that staff had. Not just he himself, but that staff had doing medicine. So how can we hold up our brothers and sisters, our nurses and doctors? What mechanisms can the music serve for them? Again, we're not doing music therapy to them. We're doing community music with them, thinking of Nigel Hartley's wonderful book on that. But we need to have modes of expression for ourselves and for others. So building new frontiers is including beliefs, honoring the patient's experience. Dory talked about tones and timbres. We don't read too much about tones and timbres in the research, but we also need to be there in the moment with the clinical nuances and the words we use. Not to call someone a cancer patient, perhaps, not to call someone my patient, but the subtle way we represent what we're doing with words is critical. So in summary, I see two areas of growth as we harvest new frontiers. One is the vertical growth. That goes this way. It's the research that investigates music and really getting into the music application. It's looking at the music through the verbal and then the verbal to the music. And Paul Nolan's written about this. It's also looking at live music and how we describe music therapy. What's our language? Please don't tell me it's just mirroring. Mirroring's wonderful, but now there's mirroring neurons, right? And we don't want to be narcissists. So what does mirroring mean? Explain what mirroring means. What are you doing? Don't just write it for your log and act like it's taxes, or for your IEP, or for your vice president. Let's really develop the language. How does music evoke emotional response and stimulate symbolic representation? That's a large area that I'm not reading enough about. So this is our music medicine and music therapy growth. Our horizontal growth is working with the community, caring for the caregiver, having music circles, seeing this as part of our role in a dignified way. Not, oh yeah, come sing, I'll play Stairway to Heaven for you. No, really looking at the dynamics of where we work, researching with doctors and nurses, reminding people on the team that every patient is a culture, and just because you've studied Puerto Rican music doesn't mean you understand a Puerto Rican patient. That's not what I'm talking about. I'm talking about every person as a culture and having a model and method for evaluating that culture and where they stand in their families. So that's the horizontal growth. Yep, mixed methodologies, mixed designs, quantitative and qualitative, more environmentals. Here we're doing more and more research in fragile populations, fragile environments. So chemotherapy, radiation. Let's go where people aren't going, and let's go in there where people are not writing so much. So treatment happens, right, with the patient, not to the patient. And let's have forms of connection. I put environmental music therapy there, thinking about working with the sounds in those fragile environments. I think I'm going to stop here. I have more slides. I did want to talk a little bit about the Musica Medicine Journal, where some of the speakers have written articles. Deborah Salmon's written a wonderful article about chemo brain and her research. Dr. Tramo, there's a copy out on the table. I just think the more that we can collaborate our research and program build with other departments is really where we're going to head toward those new frontiers. Thank you.